When transitioning from passive range of motion to active assistive, it must be recalled that all postoperative shoulder patients will have retained a certain percentage of their pre-surgical history in the form of pathomechanical motor memory. An analogy I utilize to teach postoperative patients in their recovery of coordinated movement health is much like buttoning our shirts, meaning we need to start in the right hole to end in the right hole. This also holds true for persons living with either chronic neck or shoulder pain and its associated pathomechanics. If movement begins with a compensation, once in flight, we cannot remove the onset of a substitutive motor response. We would need to start over and recognize the parameters of preserving the required therapeutic threshold within each patient's current capacities. As a patient's presentation of motor control, including activation and endurance, are revealed, specific portions of the rotator cuff, as can be seen here with the isolation of the frequently inhibited supraspinatus, being neuromuscularly re-educated for its critical role as an early force couple to the deltoid. As recovery progresses, respective roles of the remaining rotator cuff and broader shoulder girdle can be progressively targeted for their dynamic roles and immediately integrated into greater and greater functional expansions of each patient's specific needs.
A second analogy that offers clarity for patients grading their strength recovery is the comparison of a dimmer light switch and a standard on-off switch. For a weakened portion of the motor system to recover, we cannot accelerate the pace of efforts from off to immediately on, as this approach reminds the recruitment of substitutions to resume a compensatory response. Instead, as nature's law of the motor unit describes, to nurture the process gradually like a dimmer switch.